Hi everybody, this is Chris Morosky, and this video is on ectopic pregnancy. It's part of our reproductive conference series. The goals and objectives for this video are as follows. Review the classic presentation of a ruptured ectopic pregnancy. Discuss the diagnosis and management of ruptured ectopic pregnancy. Consider salient points for the exam related to this topic, and provide free and open access digital reference materials related to the topics reviewed in this video. So let's start off with patient number 3, BG. BG is a 21-year-old Caucasian G1P0 at 6 weeks by her last menstrual period who presents to the emergency department with a complaint of left lower quadrant pain and vaginal spotting. The patient just found out that she was pregnant with a home pregnancy test today. This was unplanned and she is undecided about whether she wants to continue the pregnancy or not. Her pain began 2 hours ago when she was having sex with her boyfriend. The pain is sharp in the left lower quadrant, but also crampy in her lower back. She has a small amount of vaginal spotting. What additional questions and history would you want to get from this patient? The additional questions and history you'd want to get from this patient include the following: a complete history with focus on obstetrical and gynecological histories. Specific to the history of present illness, you would want to ask about the 7 parameters of pain, including location, quality, severity of her pain, as well as worsening and alleviating factors, radiation, and if she's ever had a history of this type of pain before. You would want to get further quantification of her vaginal bleeding. You'd want to ask her about bowel and bladder symptoms, take a thorough sexual history, screen for sexual assault and domestic violence, and ask about risk factors for miscarriage and ectopic pregnancy. So let's see what are the pertinent positives for our patient BG. On review of systems, there is no recent trauma, no sexual trauma, the patient is in safe relationships, there are no bladder or bowel symptoms, no fevers or chills, and no flank pain. In her histories, for obstetrical history, this pregnancy is her first pregnancy. On GYN history, she has no pap smear history. She is 21 and should begin pap smears this year. She was treated for chlamydia at age 19. She is sexually active and has 3 current male sexual partners in the past month and 7 sexual partners in her lifetime. She is not using any form of contraception and occasionally uses condoms with sexual intercourse. She has no surgical history, and her medical history is significant for anemia, for which she takes iron. She has no known drug allergies. She is a never smoker, she denies alcohol consumption, and occasionally uses marijuana. She is a fast food worker who is single. Her family history is only significant for her mother, who has overactive thyroid. What physical exam would you perform? The physical exam that should be performed for this patient includes the following. She should have a full set of vital signs, and you should observe her general appearance. A heart and lung exam should be performed as well as an abdominal exam. A pelvic exam should be performed, including inspection of the external genitalia, a speculum exam, and a bimanual exam. Likely, a rectovaginal exam would not need to be performed on this patient. Let's review BG's physical exam. Her vital signs. She is 5 feet 6 inches tall and 176 pounds. Her blood pressure is 94/56 and her heart rate is 112 beats per minute. Her respiratory rate is 20 breaths per minute and her temperature is 98.9 degrees Fahrenheit. On general appearance, she is obese, alert, oriented, and uncomfortable. Her cardiovascular exam is regular tachycardia with a normal S1 and S2. Her lungs are cleared to auscultation bilaterally. On abdominal exam, her abdomen is soft, obese, tender in the left lower quadrant with voluntary guarding. On pelvic exam, she has normal female external genitalia, normal vagina and cervix on speculum exam. There is a small amount of blood in the vagina. She has a normal small and inverted uterus on bimanual exam, and there is moderate left adnexal tenderness. She has cervical motion tenderness. The rectal exam is deferred. What additional labs and testing would you order? The following additional labs and testing should be performed on this patient: a complete blood count, a type and screen. It is very important to check her Rh status with any pregnancy, including early ectopic pregnancies, as she would require RhoGAM if she was Rh negative. Also, this patient appears to be hypovolemic with a low blood pressure and tachycardia and exam findings that are concerning for ruptured ectopic pregnancy. She very well may need a blood transfusion, and it would be important to obtain a type and screen for transfusion if needed. You would want to obtain a serum quantitative Hcg level and perform a transvaginal ultrasound of the pelvis. Importantly, when evaluating patients for ectopic pregnancy or early pregnancies and miscarriage, it is important to understand the concept of the discriminatory zone. The discriminatory zone is the range of Hcg values in which an ultrasound can first detect the signs of an intrauterine pregnancy. Transvaginally, an ultrasound should be able to detect an intrauterine pregnancy with an Hcg level of 1500 to 2000. Transabdominally, the range is slightly higher at 5000 to 6500. Also important to understand is the concept of an Hcg doubling time. Looking at the graph here taken from perinatology.com, it's pretty easy to see that from about 5 weeks to 10 weeks, the serum Hcg level should double every 2 days. This lets you know about the viability of a pregnancy and gives some suggestion about its location. It's important to keep in mind that the majority of healthy, normal, viable intrauterine pregnancies will double every 2 days, and the majority of ectopic pregnancies will not. However, using the 20% rule, approximately 20% of intrauterine pregnancies will not double every 2 days, and approximately 20% of ectopic pregnancies will double every 2 days. And therefore, clinical judgment and repeat exam and ultrasound findings are important in determining if a patient has an intrauterine or ectopic pregnancy early in pregnancy. Alright, let's move on and see what were the results of the further workup that we wanted to do for our patient BG. Her ultrasound result returns as a normal uterus, which is aneverted, measuring 8 by 5 by 5 centimeters. There is a homogeneous myometrium, and there is a small amount of fluid in the endometrial canal. The right ovary measures 2 by 3 by 3 centimeters. The left ovary measures 3 by 4 by 4 centimeters, with an adjacent complex cyst measuring 3 by 3 by 4 centimeters. There is positive pelvic free fluid measuring 3.7 centimeters in maximum depth. Her beta Hcg level is 2,349, her blood type is B positive, her hemoglobin is 8.7, and her hematocrit is 25.0%. What options do you discuss with her? Importantly, before reviewing the options with the patient, let's go over some of the ultrasound findings that were discussed above. This first ultrasound picture shows an empty uterus with free fluid. The uterus can be seen in the middle of the ultrasound picture as labeled with the small letters uterus. Just underneath the word uterus, you can see a very thin, homogeneous endometrial stripe. What is meant by an empty uterus is there is no pregnancy seen within the endometrial canal. Furthermore, below the uterus is a large amount of dark, hypoechoic or anechoic fluid, in this picture labeled fluid. This likely is representing blood in this setting, as the patient is pregnant, there is no intrauterine pregnancy, and she has all of the exam findings consistent with a ruptured ectopic pregnancy. Moving on to the next ultrasound pictures, these are clear ectopic pregnancies seen on transvaginal on the left and transabdominal ultrasound on the right. On the left transvaginal ultrasound picture, the ectopic pregnancy can be seen in the middle of the ultrasound. What is present there is a yolk sac and an embryo inside the gestational sac. Just to the right of the ectopic pregnancy can be seen complex fluid, which likely represents a blood clot. On the right, the other pelvic structures are identified for you. Starting from the left, there is the uterus and transverse view. In the middle is the ectopic pregnancy with the gestational sac and yolk sac present. And then to the right of that is the transverse view of the left ovary. These are both very clear images of ectopic pregnancies, and if put together with the preceding photo, will have you highly suspicious of a ruptured ectopic pregnancy. Alright, so moving on to options that you would want to discuss with this patient at this time. For all patients with ectopic pregnancies, the options to consider are surgery, including salpingectomy, surgery to include salpingotomy, or medical management with methotrexate. However, for this patient, given the fact that she has hypotension, tachycardia, rebound, pelvic tenderness, and ultrasound findings that are consistent with a ruptured ectopic pregnancy, she would not be able to have medical management with methotrexate. So this patient's going to have to urgently be taken to the operating room. Also, consideration needs to be given to the management of her hemorrhagic shock and likely ongoing bleeding. So this patient's going to need a blood transfusion of packed red blood cells, so you're going to be in communication with your blood bank. You do know her blood type, so you can probably get her cross-matched blood. If you couldn't, you'd want to start thinking about transfusing her O-negative blood. She needs 2 large bore IVs, and prior to getting the blood transfusion going, she would need IV fluid running in very rapidly. Normally, normal saline would be used at this time, but lactated ringers or really anything at this point would be fine just to keep her blood pressure up. And you're going to want to stay in really good communication with your OR staff, your anesthesiologist, and the blood bank that you may need ongoing transfusion of various blood products. And last but not least, you as the surgeon need to take the patient to the operating room and stop her bleeding. There would be a discussion with the patient briefly around performing salpingectomy, which is complete removal of the fallopian tube, as well as salpingotomy, which is cutting open the fallopian tube and just removing the ectopic pregnancy. So, let's talk about the follow-up for patient BG. The patient undergoes urgent laparoscopic salpingectomy for a ruptured left fallopian tube ectopic pregnancy. Her ER cultures return is positive for chlamydia. You discover this 2 days after her surgery and before her return office visit. So before we talk about her return office visit and treatment for her chlamydia, I've put together a few short clips of videos showing ectopic pregnancy, laparoscopic salpingectomy, and laparoscopic salpingotomy. So this first video is a diagnostic laparoscopy for a ruptured left fallopian tube ectopic pregnancy. This second video is a video of a left salpingectomy, or removal of the fallopian tube, for ectopic pregnancy.
The operation started by grasping the isthmus of the tube and cauterizing with bipolar diathermy. The isthmus was cut. The operation proceeded cephalad along the mesosalpinx, keeping as close to the tube as possible. Finally, the tubal ligament with the blood supply were cauterized and cut. The whole tube with the ectopic were excised, placed in a laparoscopic bag and removed.
Finally, in this last video, this is a good demonstration of a laparoscopic salpingotomy taken from this person's YouTube channel. If you want to watch all of these videos, you can use these links.
Vasopressin was injected on the antimesenteric border of the tube with the ectopic pregnancy. An incision was made with a diathermy on the antimesenteric border of the fallopian tube. the ectopic pregnancy was gently pulled out. The defect was washed and the bleeding spots were coagulated.
Okay, now having finished watching these surgical videos, I do want to briefly review some of the important parts about use of methotrexate, as it sometimes shows up on your exam. This patient would not be able to use methotrexate as treatment of her ectopic pregnancy, again because she has a ruptured ectopic pregnancy, and that's one of the absolute contraindications. So it's going to be important for you to review the absolute and relative contraindications to the use of methotrexate to treat an ectopic pregnancy. This can be found in the APCO video as well as your textbooks. Importantly, the dose of methotrexate for the treatment of ectopic pregnancy is 50 milligrams per meter squared body surface area. And this is the point that usually comes up a lot. From day 1 to day 4, so day 1 is when the patient receives the methotrexate and you have a baseline Hcg level. From day 1 to day 4, we anticipate the Hcg level to rise. This is because the syncytiotrophoblasts and cytotrophoblasts all burst and release their Hcg. But, however, from day 4 to day 7, there needs to be a 15% or more drop in the Hcg level. If the patient has less than this, she's given the option to have a second dose of methotrexate or to have surgical management for ectopic pregnancy. For patients who do have this drop, we normally follow their Hcg levels until they're at least below 200. Some of us are a little bit even more cautious and we follow them down to 0. And this Hcg level is drawn weekly. Similarly, for patients who undergo salpingotomy and removal of the pregnancy but not the fallopian tube, this is sort of the same schedule that we use for checking Hcg levels. Okay, now moving on to contraception. You call the patient to treat her cervicitis. She does not want to become pregnant. What top 3 contraceptive options would you discuss with the patient? Which leading option would you recommend and why? In discussing contraception with this patient, you would want to use a shared decision-making model. You would want to review with her all of the different contraceptive options, and you would want to balance her preference and the side effects of the contraceptive options with the efficacy for contraception of all of the different choices. Importantly, if you and the patient decide upon IUD insertion, she has a positive chlamydia cervicitis, and this needs to be treated prior to IUD insertion. In fact, you need to treat her and you need to re-screen her for chlamydia cervicitis approximately 3 to 4 weeks later. You'd want to do this prior to placing her IUD. Now, for patients who present for an IUD in the office, you can insert the IUD and perform the gonorrhea and chlamydia swab at that time. If they turn out to have a positive gonorrhea or chlamydia asymptomatic cervicitis, you can treat their infection without removal of the IUD. However, for this patient, since you know she has a positive chlamydia test prior to insertion of the IUD, you would want to treat her cervicitis first, have a negative test of cure screen, and then place her IUD. It's important for this patient to discuss condoms and how they can be used to prevent STDs, not just chlamydia, but various other STDs. You also would want to offer her screening for all forms of STDs, including hepatitis B and C, HIV, and syphilis. As part of your education, I think that it's very important to at least show you today 2 of the CDC apps that are out there, one on contraception and one on STD treatment. So here they are right here. The first one is the U.S. Medical Eligibility Criteria for Contraceptive Use. This is a very helpful app because this can help you select which form of contraception is safe and effective for patients based on their other medical issues. And then there's also the CDC STD Treatment Guide, which is one of the best apps that's out there. It's small, it's concise, and it goes over all of the STD treatment guidelines. And it also has really good information and a small summary on the different types of STDs. Alright everybody, that's the end of this video. Just to review the goals and objectives, we reviewed the classic presentation of a ruptured ectopic pregnancy. We discussed the diagnosis and management of ruptured ectopic pregnancy. We went over some of the salient points for the shelf exam related to this topic, and we just at the end here provided some free and open access digital reference materials for topics related to ectopic pregnancy and STDs and contraception. Alright, thanks for watching. Have a great day. Bye-bye.